And we are going to get started with a presentation from Mary Beth Cox. And I think you have Fisher with you as well. And so you are able to share your screen. I will just say that I'm so appreciative for them being here because we've talked about alcohol being a contributing factor for opioid overdose. And so they're going to shed some additional light on that. And you are able to share your screen. And so please go ahead and do so.
Thank you so much, Dr. Boone. Let me make sure I share the right screen here. And y'all are seeing my mess of a desktop now, and hopefully that looks good. You're seeing slides now?
Yes, and your desktop looks like mine. I am shocked.
It's just so convenient to save it to the desktop.
Yes, absolutely. Please go ahead, and we appreciate it.
Thank you so much. I'm actually going to turn it over to my colleague Fisher to have her start the presentation with alcohol surveillance, and then I'll take over for the overdose portion. So Fisher, go ahead and take it away.
Yeah, hi everyone. My name is Fisher Charlton, and I'm an alcohol epidemiologist with the North Carolina Division of Public Health. And today I'm going to be talking a little bit about the alcohol-related harm surveillance in Durham County. And next slide. So before we get started, I wanted to make sure we're all on the same page about why I'll be talking about alcohol attributable death rates instead of the counts of individuals who died. So while both are important, rates help us when we talk about disparities. And here we're looking at an estimated number of individuals who died of an alcohol attributable death by age. And on the left-hand side are the counts of white, non-Hispanic, and orange, with the counts of Black, non-Hispanic, and blue on the right-hand side. And as you can see, counts amongst white, non-Hispanic residents are much higher. But when we really start to think about it, of course they're higher because this is a much larger population in the state. So we're really comparing apples to oranges here. Next slide. So now we're looking at alcohol attributable death rates in the two communities. And what we've done is adjusted for the differences in populations in the two communities. And we see a different story unfold. For many years, Black residents have had similar rates or even higher rates than white residents. And as we'll see later in this presentation, the same concept applies at the county level. And today we'll be focusing on rates. I can't hear nothing. Oh, sorry. Can you all hear me?
Yes, I can hear you very well.
Yeah.
Okay.
Yes, I can hear you.
Okay, great. I will keep going, but hopefully someone can figure out their audio. I think this is being recorded, so okay, great. Yeah, so tonight we'll be focusing on rates in Durham County by white non-Hispanic and Black non-Hispanic residents. And age-specific rates will be shown to help account for the differences in alcohol consumption patterns between different age groups. And next slide. So this is just a really staggering stat. With deaths in 2021, we've now reached an average of 17 North Carolinians dying every day from a death attributable to excessive alcohol use. Next slide. So what do we mean when we talk about excessive alcohol use? When talking about an alcoholic drink, one drink is equivalent to a 12-ounce beer, a 5-ounce glass of wine, or a drink with one shot, which is 1.5 ounces of liquor. And excessive alcohol use is defined as binge drinking, which is 4 or more drinks in one sitting for women and 5 or more drinks in one sitting for men. Heavy drinking, which is 8 or more drinks in 1 week for women and 15 or more drinks in 1 week for men. Or any alcohol consumption by pregnant persons or people under the age of 21. Next slide. So in order to calculate alcohol attributable deaths, we use CDC's alcohol-related disease impact tool, which is also known as RD, which provides estimates of alcohol-related harms. And death estimates are calculated for 58 acute and chronic causes of death using alcohol attributable fractions. And these fractions really measure the total proportion of deaths from various causes that are attributable to excessive alcohol consumption. So for example, the fraction for liver cancer among males is 0.20. So that means an estimated 20% of liver cancer deaths among males is attributable to excessive alcohol use. And the CDC does provide these fractions based on differences by sex and age, which is based on available literature and data, but fractions by race ethnicity aren't available. So while we can calculate death estimates by race ethnicities, deaths can differ across race ethnicity groups because of differences in deaths from any particular cause, and not necessarily because of differences in alcohol involvement. Next slide. And here are just some examples of alcohol attributable deaths. So some causes of death are acute, which may be what you might typically think of, such as deaths from firearms, motor vehicle crashes, or alcohol poisonings. However, many deaths are attributable to chronic conditions, so deaths from things like liver disease, heart disease, stroke, and certain types of cancer. Next slide. So again here, white residents are represented by the orange bars, while Black residents are represented by the blue bars. And a couple of slides ago, we saw the total rates in North Carolina were relatively similar between Black and white residents. However, in Durham County, we see a different story. We see that Black residents have a higher total alcohol attributable death rate for every age category. And there's also a large difference between the two groups. And these findings can be considered within the context of persisting health inequities, which along with many other factors could have contributed to the observed disparity. Next slide. So while looking at chronic or total alcohol attributable deaths gives us a piece of the puzzle, we also need to look at the breakdown by acute and chronic. So patterns of alcohol consumption tend to differ between these causes. And chronic causes result from long-term excessive use of alcohol. So from things like a lifetime of heavy drinking. And there are 40 causes, chronic causes such as alcoholic liver disease, heart disease, stroke, and certain types of cancer. Next slide. And so this slide has a similar layout to previous slides, but here we're going to be focusing on those chronic causes. And due to low counts, age-specific rates couldn't be calculated for those 34 and younger for both Black and white residents in Durham. But it is important to note that chronic causes of alcohol attributable deaths generally occur most often in those older age groups. So in Durham, the rates for chronic causes were higher for Black residents aged 50 and older when compared to white residents of the same age group. And we also saw a similar story statewide. Next slide. So in order to fully understand alcohol attributable death rates, we also need to look at those acute causes of death. And acute causes result from short-term excessive use of alcohol, such as binge drinking. And there are 18 acute causes, such as alcohol poisoning, other drug poisonings, homicides, and suicides. Next slide. So again, this slide has a similar layout to the previous slides, but we're focusing on those acute causes here. And just thinking back to those chronic causes for a minute, we saw that Black residents aged 50 and older had higher rates in Durham. And with acute causes, we see a similar picture. Black residents had higher acute rates for every age group. And there's a little bit of a different story statewide, with Black residents having higher rates for those aged 34 and younger, while white residents had higher rates for those aged 35 and older. Next slide. So while those other slides highlighted all alcohol attributable deaths, we're now going to focus on a singular cause of death, overdose. So different from previous slides, the numbers on this slide were calculated using death certificate codes that tell us what substances, including alcohol, were involved in a person's death. So while we did talk about alcohol poisoning, these deaths are primarily caused by other substances. And it's important to understand the role alcohol plays in the overdose epidemic because alcohol in combination with other drugs can increase a person's risk of overdose. So in Durham, percentages for Black residents have remained relatively high, with 1 in every 5 overdoses involving alcohol use. And in North Carolina, Black residents had a similar percentage as those in Durham from 2017 to 2021. Next slide, please. So while that's all the alcohol-related data I have right now, I wanted to discuss the additional resources that we provide. For more information, please visit our website, which contains data, information, and resources about excessive alcohol use. And I wanted to highlight one resource in particular, the North Carolina Alcohol Data Dashboard, which provides the public health narrative of the acute and chronic impacts of excessive alcohol consumption at both the state and county levels. And the QR code for that can be found on this slide. And in addition, we also started a group, the North Carolina State Excessive Alcohol Advisory Committee, also known as NCCAC, which engages partners working in the prevention of excessive alcohol use and its related harms across the state. And this committee really hopes to develop and implement a statewide plan to address excessive alcohol use and its related harms. And meetings focus on excessive alcohol use prevention strategies presented by subject matter experts. And these meetings actually happen twice a year, and the next one is in October. So if you're interested in participating in this group, please email either email listed on the slide here. And then for any alcohol-related data requests, please email substanceuse.data@dhhs.nc.gov or book an appointment with one of our epidemiologists through the
walked in the door. I have a meeting.
Through the Injury and Violence Prevention Branch's data bookings application. And next slide, please. And I'll turn it over to Mary Beth.
There we go. Thanks, Fisher. I couldn't find my mute button in the screen share. Thanks, Fisher, for that great presentation on excessive alcohol use and its related harms in Durham and the state. I'm going to take over kind of where Fisher left off with alcohol's involvement in overdose death, and now zoom out a little bit and let's talk about all the overdose trends, both nationally and in North Carolina, and Durham as well. The folks on this call are probably well aware of the impacts of the COVID-19 pandemic on folks who use drugs and the overdose epidemic. We saw nationwide in 2020, the first time we broke over 100,000 overdose deaths nationally. Those numbers have continued to increase in years since. And North Carolina, unfortunately, our story is not much different than the national story. So in 2020, that first year of the pandemic, and you can really see it down to the month when March 2020 rolled around, where we see this large increase in the number of overdose deaths in our state. It's actually, we experienced a 40% increase in overdose death in 2020, followed by, in 2021, a 22% increase in overdose deaths, reaching the grim record of over 4,000 North Carolinians losing their life to a drug overdose that year. And this is, after the first decrease that we had seen in nearly a decade in this epidemic. So definitely severely impacted by the changes in access to care, stressors, mental health stressors, changes in consumption, access to their treatment and social supports and things that were disrupted in those early years of the pandemic. And just taking a moment to pause and understand really the scope and scale of this epidemic. That's an average of 11 North Carolinians dying every day from a drug overdose. And we're talking a lot of numbers and data, and just want to make sure that we're all remembering that these are people, and people who had family, friends, they were part of community, and there's really not anyone in the state or the nation probably anymore that hasn't felt the impacts of this epidemic. I do know that I'm sharing 2021 data. We're nearly halfway through 2023. It takes a really long time to finalize death data, especially. And so while we wait for the final death numbers for last year, there are some indicators that we can look at that are a little bit more timely than those final death numbers. And so you're looking here on the left at suspected overdose death. This is a measure that our partners at the Chief Medical Examiner's Office put together. And then on the right-hand side, those are year-over-year ED visit data for a drug overdose. And these are statewide numbers. And they are much more timely indicators than the finalized death data. And really what I want to highlight here is in 2022, we still are estimating about a 7% increase in the number of deaths. And then ED visits, a very, very slight, less than 1% increase. All of that to say, it seems as though the rate at which overdose has been increasing is starting to slow down, but we are still sustaining those really, really high numbers that we saw in early years of the pandemic. And the provisional, like, first 5 months of 2023 data that we can look at for these two measures are showing a similar story. We're kind of holding steady at these very high numbers. I'm going to move on to talk about the communities who are most impacted by this epidemic. Certainly, again, acknowledging that most everyone feels the impact of the overdose epidemic at this point, knows someone who's been impacted if you haven't been impacted directly. But certainly more communities, some communities are disproportionately impacted. Most of this presentation will focus on those disparities by race. And I just want to acknowledge that we are using race as a proxy measure for the impacts of historical and systemic racism that really runs throughout every single facet, every system that someone might come in contact with in this country is built on a system of racism and white supremacy. And so we're not saying that one race is inherently more likely to experience a fatal overdose. We're really trying to measure the impacts of all of these structures that are set up to deny people access to education, food, treatment, healthcare, the list goes on. And I think it's especially important to keep this framing in mind when we're talking about the overdose epidemic and recognizing, the decades of the war on drugs and how the impacts on communities of color, particularly Black communities in this country, when we're talking about substance use disorder, drug use, and we just don't have, there's not a way to measure that with death certificate data. And so we are using race because that does exist on the death certificate. We're using that as a proxy measure for all of these much more complicated systems that are in place. So thinking about those rates by race, ethnicity, what does the state of things look like in, again, still looking at the statewide data at this point. In addition to looking at the overall rate, and Fisher did a great job of talking about why we talk about rates when we're comparing different groups instead of just the raw count of people. Both are important to consider, both the count and the rate, but when we're comparing groups, we want to standardize by the population. So we're talking about rates here. I don't want to just think about the overall rate. I want to also think about how quickly is that rate increasing, or just what is the change happening. So this is from a press release that we put out earlier this year when we got the final 2021 data. So we were talking about that 22% increase statewide, but we also looked at rates by race and ethnicity. We looked at 2019 and then 2021. So this is, here you're looking at the percent increase over a 2-year time period, really trying to get at that pre-pandemic to most recent year of data that we had available. And you can see that even though the non-Hispanic Black population had lower overall rates, their rate is increasing faster than other populations. They had 139% increase in this 2-year time period. Indigenous populations in our state had 117% increase, and that's compared to a 53% increase in the non-Hispanic white population. This story is not unique to North Carolina. It's been widely reported nationwide that we're seeing these same racial disparities widening, particularly in Black and Indigenous communities across the country. And for those who, like to see the graph instead of a table, just a different way to visualize that same change over time and different fatal overdose rates by race and ethnicity. You can see, for many years, the indigenous population and the white population had very similar rates. Beginning in 2018, we start to see the indigenous rate breaking apart, got very, very high over the course of the pandemic. And then want to zoom in here on the statewide difference in the Black and white populations, and how for many years, non-Hispanic Blacks had lower rates. And that gap that existed before has really started to narrow. And essentially in 2021, the rates almost equal there between non-Hispanic Black and non-Hispanic white residents of North Carolina. So getting to Durham's data now and thinking about that same setup, looking at the differences in the rate of overdose, fatal overdoses between non-Hispanic Blacks and non-Hispanic whites in Durham County, we see a different story than what I just showed you on the statewide slide. So just harkening back to the statewide, we had that gap for many, many years and then closing in on that gap, but white rates are still higher statewide. In Durham, the rates have been equal for many years, very similar. And then with the increases that both demographics have experienced since the COVID-19 pandemic, we really see a much sharper increase. That the slope of that line, we think back to algebra class, that's how quickly things are increasing. We see a much steeper slope for the non-Hispanic Black population, and that gap is much wider in Durham. And this is looking at emergency department data and just acknowledging really a similar story in Durham. So from 2019 to these are provisional 2022 data. We've experienced this, Durham has experienced a 75% increase in the disparity ratio between Black and white residents. So just to walk folks through kind of how to interpret these numbers, this is the rate ratio. So the Black to white ratio in that rate of non-fatal ED visits for a drug overdose. And so essentially if there's a 1 here, the rates are equal. And so that I don't know if you all can see my mouse, but hopefully you're seeing my mouse here, this bottom 2019 North Carolina rate, almost equal. So rates statewide between Black and white residents, fairly equal in 2019 for ED visits. And then we start to see over the course of this 4-year time period, things change a little bit, and now statewide, this 1.1 indicates that the rate for Black residents is slightly higher in the statewide data. Durham, on the other hand, the first row of data here, Durham has always had a rate higher for Black residents when we look at drug overdose ED visits, and that has continued to grow over the course of these 4 years. And this 2.27 really means that the rate of overdose among Black Durham residents is over twice as high as the rate for white residents. So again, seeing that disparity kind of growing over these pandemic years. And the last point I want to make about the communities who are most impacted is thinking about where folks live and how important place matters when we're talking about public health and thinking about the built environment and all of the impacts that can have on a community. And oftentimes, you see a map of North Carolina with our 100 counties, and this is when we share in every presentation I do about overdose. And we're looking here at a 5-year time period. I typically share that the rate of fatal overdose ranged from 12 deaths per 100,000 to 63. So quite a span among our counties. Again, we're talking about rates so that we can compare across counties, right? You'd expect Mecklenburg to have a higher count or Wake to have a higher count than a smaller county. So we've standardized by population. Statewide, the average rate was 28 deaths per 100,000, and Durham's rate was 21 deaths per 100,000 in this 5-year time period. So, we could look at this and say, great, Durham is one of those lighter shaded counties, lower than the state rate. We're doing okay relative to the state as a whole. But something we have been thinking about a lot more in the work that we do is going beyond the county as a whole and zooming in to look at like a more detailed picture. So you're looking now at the census tracts within Durham, and a census tract is really like divvying up the county in a way that each of these kind of blobs has an equal number of people living within it. So you think like the more rural areas, it's a bigger area because it's less dense population. There are census tracts here in this gray space, but the overdose numbers were so low that we didn't include them in this map. But I want to remind you here on this slide of, Durham had an overdose rate of 21 deaths per 100,000, and the range statewide at a county level is 12 to 63. I don't know if you all can see the scale now when we're looking at census tracts, but the range is now 11 deaths per 100,000 to 110 deaths per 100,000. So a darker shaded census tract, these more densely populated areas, we're thinking about who lives in these areas. This is really the folks who are most impacted by this epidemic in Durham County, and where to focus resources. But when we scale back and we look at the county as a whole, that rate, the story and the rate get a little skewed because we're considering the entirety of the county. So we are trying to do a lot more work in this space, this sub-county analysis. It does get a little bit trickier with suppression of low numbers and what is a stable rate and making sure we're telling an accurate story. But I think it's just really important to acknowledge the difference that we see when we go deeper with these analyses. And I will very, very quickly wrap up with some of our resources, just so folks are aware. We also post a lot of overdose data, always at the state and the county level on our website. I think you all are like super users of our monthly surveillance reports that go out. Thank you so much for making use of these. If you ever have questions or you don't receive these and want to, please email us at that same email address, substanceusedata@dhhs.nc.gov. And feel free to reach out and book time with one of us. You can book time on any of the injury and violence topics that our EPI team supports, and we can talk through your data needs. We are really here to serve citizens of North Carolina doing the work that you all do day in and day out, and we want to be a resource to you all. And finally, if you're not connected to the North Carolina OPDAC, I encourage you to sign up for that listserv and attend those quarterly meetings. It's a great place to learn about work happening across the state and get connected to the community of folks who are working in the overdose space. I will leave our contact information up there, and I think I'm turning it back over to you, Dr. Boone.
Thank you so very much for your presentation. This is a discussion that we've been having for a while. And so I reached out to you so that we could have the experts to provide the information to us. And so we have a better understanding of what's happening in terms of opioid overdoses and the connection with alcohol. Before I go on, does anyone have any questions for Fisher or Mary Beth? Okay, so next I'm going to be talking about what we in Durham are doing in terms of prevention. You've seen the data, and so I will go ahead and share my screen so that I can talk about that. Let me see, let me move this out of the way. So many of you know who T.R.Y. is and what we do, and we are the prevention arm of Durham Joins Together to Save Lives. And so just as you heard in the presentation, we've drilled down, even though we provide information for everyone in Durham County in terms of information, we do understand that there is a larger conversation and action that needs to take place in other parts of our county, as you just heard. So within districts 1 and 4 are the most vulnerable census tracts, and you saw a presentation about that. You see information about the poverty level, 37% of residents are below 200% of the federal poverty level in these districts. I have a lot of information about the districts that I am not particularly going to share tonight. But residents in districts 1 and 4 have faced adverse childhood experiences and trauma, and ACEs of 4 nearly doubles the risk of heart disease, lung cancer, increases the likelihood of becoming an alcoholic, according to data. And ACEs are increased due to community violence, natural or human-made disasters, forced displacement, poverty, and discrimination. And there's a growing body of research that has found a link between traumatic childhood experiences, physical and behavioral health problems in adulthood, including smoking, alcoholism, drug use, missed work, depression, suicide attempts, etc. And so even though we're focused tonight on overdoses and alcohol and how we're preventing those harms, we have to keep in mind that as we're addressing those, there are still other challenges that are going on in the districts that we are addressing in terms of prevention as well. Substance misuse, of course, have connections to substance use in youth, failure in school, suspensions, arrests, etc. And so the prevention goals that I am presenting, the goals, objectives, and actions, address the disconnects within the community, among institutions, within families, with youth. And the project focuses on trauma and monitors the Good Neighbor Business Network. There are different levels of things that we're seeing, and I question these first 2 pieces of information that I'm going to get a little bit more of an update on. They look really, really, really good because in the last 2019, 23% of high school students reported using alcohol. So I'm going to check on that. But if these numbers are good, they're great. And then just for our own information, we have information on marijuana because Durham Joins Together to Save Lives initially was focused on and continues to be focused on opioids and opioid overdose. But we also have a commitment in terms of prevention to address other drugs, including prescription drugs, et cetera. Court-involved juveniles, 52% report using alcohol and other drugs. Again, our focus is on prevention. Gang-involved individuals report using weed and other substances, and some gang members, according to the gang report, use weed more than once a day or once a day. Yes, and so you see those numbers there. In terms of trauma, stress, adverse experiences, 32% of middle school students report feeling depressed for more than a 2-week period. High school students, 35% over a 2-week period. 27% of middle school students ever considered suicide in the past 12 months. 19% of high school students considered suicide in the past 12 months. And with court-involved young people, 37.6% had mental health issues, 45% need more mental health assessment. When we think about who lives in these vulnerable areas, as pointed out by Fisher and Mary Beth, and also in the information that I showed previously, we understand there is an area of focus that we must have. So our goals are, and I'll send this out, I'm certainly not going to read this all to you, but strengthen prevention capacity at the community level, implement community coalition building strategies. These are things that we're already doing and have been doing for quite some time, but just wanted you to see the kind of work that we're doing. And the information that Donna sent out with the agenda, I also included a few links to videos and some info sheets that help to describe the other things that we're doing. educate the community on substance use ACEs and resilience to prevent substance use and opioid overdose among adults, including Black adults. And we're also focusing on reducing underage drinking. Woo, I'm sorry, I'm in Florida and there just was a big clap of thunder. Prevent and reduce substance use among middle school and high school students, including short and long-term suspended students. Reduce substance use marijuana among juvenile justice involved youth. Prevent and reduce opioid misuse among adults, including Black adults. And so the way that we're doing this, you've heard this so many times, this is, I believe, my last slide almost. And so we use the 7 strategies of community change. We reached over 1,100 young people in the past 6 months. We have over 1 million social media reach, and that's with everybody in the coalition. Thank you, everybody who's here representing T.R.Y Coalition. But there are activities here that go along with the goals, objectives, and strategic action plan that anyone can participate in. And actually, coalition members have signed up to identify which areas of the 7 strategies for community change that they want to work in. So there is a way that we have to not only identify what we're doing, but to measure what we're doing. And we are thrilled with some of those outcomes. So anyone can share information with others, building skills, providing support, enhancing access and reducing barriers, changing consequences. Ooh, that's a big storm out there. Increasing public recognition for the deserved behavior or citations and fines for those behaviors that we don't want to see. Physical design, reducing risk or enhancing protection by using signage, lighting, or outlet density. Alcohol outlet density will take a whole presentation. And that is what we call the Good Neighbor Business Network, where we have over 550 alcohol outlets that agree to follow the law, not sell to minors, not selling to intoxicated individuals, but they have become prevention assistance in that they also post or provide information to the community that we give them on alcohol misuse, opioids, COVID-19, vaccines. And so we have a plethora of partners that are assisting. The Good Neighbor Business Network, we also get information on non-compliant sites, and we assist them by helping to train them as well. So when we talk about alcohol misuse and providing information, I just want to very briefly say that we are not, in favor of prohibition. So that's not what we're trying to do here. And Fisher and Mary Beth did a great job in speaking about what responsible alcohol consumption is. And so what we talk about and what we provide to the information are these facts. There should be 0 alcohol consumption while driving. If someone is pregnant or wanting to become pregnant, and if someone is on certain medications, 0 alcohol. 1 standard drink per day for females, 2 standard drinks per day for males. And what we want to make sure of is that the community is aware of the dangers associated with alcohol consumption, especially when it comes to overdose. I'm a member, I don't know if you can hear that or not. I'm a member of the North Carolina State Excessive Alcohol Advisory Board. I'm also a member of the State ACEs Advisory Board and National Overdose Prevention Task Forces, et cetera. So we stay on top of all of this information and data, and we share it to you, with you on a quarterly basis, but also during our coalition meetings. You saw this slide from Mary Beth in a different format. And let me just jump back here for a second. And so I'm going to stop sharing my screen. Everyone is open and welcome to attend the coalition meetings where we are addressing this issue through several partners, and you're all welcome to take part. Let me just ask if there are any questions about the coalition or the steps that we are taking in terms of substance use as a prevention. So we're in elementary schools, middle schools, high schools. Any questions there before we go on? Okay, so next we'll have a presentation from the Mental Health Substance Use Disorder Treatment Committee and discussing substance use at the detentions, in the detention setting, peer support program, and the SMART program. So you are able to share your screen. I don't know who's going first, whether it's Tremaine or...
Yeah, I'll go first.
Okay, all right.
Okay. Are y'all able to see my slides?
Absolutely.
Okay. All right. So for those that don't know, STAR is substance use treatment and recidivism reduction. We're housed in the Durham County Jail. Our agency is Criminal Justice Resource Center. We're going under a rebranding to Justice Services Department. Our interim director is Rashonda Parker, as you can see, and Mark Strange, our clinical service director. Beth Steinberg is our quality assurance and data integrity. So she's the one that once we put in the data, it makes sense of what we're doing here at STAR. Did my slide, did it change? Because I can't see what y'all see.
It didn't change.
I don't know how to do it then.
You can either use the directional arrows that are on your keyboard, or you should also see arrows down at the bottom left of your PowerPoint, and you should be able to forward there.
Okay, what about? Yeah,
well, we can see your next slide. So if you just want,
okay, I'll just keep on going.
Yeah.
But okay. So start this. Hopefully what you see is just pretty much how our evidence-based practices are. STAR provides up to 16 weeks of treatment for core mandated individuals or those that volunteer into the facility. To get into, I guess, the specifics of our program, this is data showing from our fiscal year 2022. As you can see, I'm not sure if you can see my pointer, but we've had 146 cases. But as you can see, there's been multiple diagnoses for individuals that are here. So that means each individual here has had at least 2 or 3 diagnoses. And this is just a breakdown as far as what our main substances that we're seeing within our program.
Mm-hmm.
The next slide just shows a breakdown of the cases by sex. As you see, the women's population is relatively small, so those numbers will be small in comparison to our male population, and that's based on the census that's here in Durham County Detention Center. Here you see again, we had 29 women and 117 men, and this is the breakdown as far as what substances and stuff they were using based on those total percentages.
Mm-hmm.
And then the next slide just shows the percentages actually of the substances. And as you can see, I guess, as far as the men, and relatively for what our first presenter show is that alcohol is one of the main things for our male population. I didn't break it down to race, but our population is predominantly African-American men and African-American women. And then if you break down, you see how our women population are using more opiates than our male population, but also cocaine. So looking at uppers and downers and stuff, stimulants and everything for them. The other represents like gambling addiction and other sedatives, other hallucinogens that are being used with our participants. And just another based on the age range as far as what's being used. As you see, cannabis is highly used with that age population as far as the transitional youth, and alcohol primarily for elderly. And as you can see, I guess the range is everything. Again, for the male population, alcohol has been the predominant, and then cocaine, and then third was cannabis. For women, cocaine was the first with 76% going back to this one. 76% for the women. Their second was cocaine, tied with alcohol. Well, yeah, no, cannabis and alcohol was third. Opiates was second, but cannabis, alcohol was tied with 62% of those 29 women. And I think, and that's it. Just short and sweet, as far as the numbers and population that we have and the substance that are predominantly used.
Thank you. Okay, so what's important about those numbers is that research shows that the more violent crimes are associated with alcohol consumption. And so whether it's youth that are using alcohol, or you see the range of ages, and these are individuals that are in the STAR program already in the jail. So when we want to prevent violence, if we want to prevent these excessive alcohol dangers, if we want to prevent opioid overdose, I think you have a better picture of how those are all interconnected, and therefore prevention has to address all of those things before they get to that point. So in elementary school, we start talking about these things, and we have tools in order to help communities do that. We don't leave them on their own. And that information is from the CDC and SAMHSA and NIH. Okay, so Lacey, you're next. Oh, I'm sorry. Does anybody have any questions for Tremaine about those numbers? Thank you so much.
No problem. And just to add to what you're saying too, we are increasing like the screening that we're doing here to Durham Detention Center, because as you saw, like a lot of people are diagnosed with alcohol use disorder, but still a larger population that aren't educated on what is actually misuse. Like you said, one drink. A lot of people don't know, I guess more than that is some problematic use. So we're doing increased screening on all substances, but specifically on alcohol use, and educating those individuals as they come in. So try to prevent them becoming or having an actual disorder in alcohol use.
Yeah, and let me clarify again, because there's a difference between binge drinking and responsible drinking. So the 0, 1, 2 was responsible drinking for everybody. Binge drinking, 4 servings of alcohol at one sitting for females, 5 servings of alcohol per sitting for males. That is extreme, considered extreme, excessive, dangerous alcohol consumption. Okay. Lacey, please go ahead.
Thanks. Hi, everyone. Good afternoon. So how do I turn this into a slideshow?
There,
I mean, I guess I can go from...
Well, you can, but at the bottom of your slide, there are notes, and then there are 4 squares, and then there's another thing, and there's a slide. Next one.
Ah, thank you. I'm used to Zoom. So I'm going to be just talking really shortly about the CLC peer support program, and then you're going to get to hear from 2 peer support specialists. We've been talking a lot about peer support in our committee meetings, and so we've got Ronald Gary, who's the peer support specialist in the detention center on the program that Tremaine just talked about. And we have Claire Bigham here, who's the peer support specialist for CLC, and they've got some really great insight to share with us. So I will just try to be real quick. For anybody that is new and doesn't know about the CLC program, it's funded through the Durham County Department of Public Health. We contract with DRRC, which is Durham Recovery Response Center. and our peer support specialists are based there. Right now, we have one full-time peer, and that is Claire. And what Claire does is she goes out into the community and tries to connect with people with substance use disorder. So we get our referrals from both of the Duke hospitals, from the EDs there and from the hospitalized patients. When they're being released, usually the provider or the patient themselves will call Claire and be referred to the program. And we also get some of our referrals from EMS. We team up with the EMS community paramedics to conduct port visits. We have a Durham port, which is the post-overdose response team. And the ambulances keep track of every overdose in Durham. And they get whatever contact information they can at the scene of the overdose. And within 72 hours, the community paramedics, along with our peer support specialist, drive to the person's home or wherever their last location was, knock on the door and try to connect with them. We give them a folder of information, a naloxone kit, and Claire talks with them and tries to get them interested in further connection and ultimately treatment. She's going to talk about the difficulties of that. It's a very hard population. Making connections is important, but they're rarely ready to engage in treatment. But they have the number and the contact information for whenever they're ready to get to that stage of change. Another place she gets referrals is the DRRC crisis unit, which is attached to DRRC, and it's very easy for her to walk in there, talk to people that are staying there after a crisis. And I think over 70% are there for substance use related crises. So she's able to get a lot of people there interested in further treatment, further peer support. I think most of our participants actually come from there. And finally, we get referrals from people being released from out of the SMART program and out of the MAT program from the detention center. So that's a lot of referral sources for one woman right now. She gets about 15 to 20 new participants each month. I know Dr. Boone has asked about that before. So on a monthly basis, it's about 15 to 20 new participants. And we really have to balance that because it's not just a one and done deal. About half of them consent to enter the program, and most of those opt to go into substance use treatment at DRRC. And they have the option to meet with Claire on a weekly basis. I mean, sometimes they're calling her even more than that for support. She helps them with housing and transportation and harm reduction. She's a certified RAP counselor, which is wellness recovery action plans. And so she's going to be setting up sessions soon to create those RAP plans. And so we want her to spend a lot of time with each individual person. Those people can stay for 3 months, 6 months, even some people staying for a year. So we have to balance sort of how many new people we're bringing in per month versus how many are in the program, so she has time to really give care to those people. If we count up how many contacts she has every month with people that are in the program, in addition to the new people, it's about 50 to 70 contacts per month. So just some very quick stats from for our aggregate data from the start of the program, which was at the end of 2019 through this February. And this is all of our data. I'm going to be diving down a little deeper into subgroups later, but this is for everybody that has been in our program for since its beginning, which is about 3 years. We've had several peer support specialists, and they've connected with 352 people out in the community, giving them the folders and the resource kits. We've distributed 171 naloxone kits. Our peers have made a total of 2,032 contacts with all program participants. And we have provided Uber rides, 552, so that these people that are participating on a regular basis can get transportation to their treatment, and other services. Will transport them to the pharmacy to pick up their prescription, to drug court, wherever they need to go. So 178 of these people, out of the 352 that we've connected with, 178 enrolled in the program to meet to meet on a regular basis with our peers, and 130 of those enrolled in substance use treatment at DRRC. Our population is very heavily male, 72% male, 28% female, and that actually is very, very close to the gender breakdown we see for overdoses in Durham. If you look at EMS statistics on the number of overdoses over the past few years, it is about 70% male. It's really a male problem, which I think we should talk about how to address. And so our population looks similar. Our average age is 39, and we have a spread from the youngest is 21, so we don't have any minors in the program. Oldest is 67. We have some missing race data from the very beginning when we weren't collecting it, but excluding that missing data, you can see that it's primarily white and Black participants, almost equal 50-50. A handful of American Indian, Alaskan Natives, and 0% Asians. Of these 178 people that enrolled, we were able to give 44 enrollees who stayed with the program for 3 months. We gave them a survey, and 71% were not using any form of opioids, 66% not using substances, 73% were still taking their MAT, and it's at our program, it's Suboxone. That's the medication. Of those 44, when they started the program, 55% had housing, and after 3 months, 84% had housing. So we're happy that we're making a bit of a difference in getting these people housing. And we asked them, what is the most helpful part of the program? And 50% said that peer or staff support was the most helpful part. So I know there's been some interest in breaking the data of our total population down further by race, age, and gender. Helen Tripp, a while back, did this for overdoses in Durham, and so I wanted to match what she did and see if ours matched up with that. Aside from the missing over here, our biggest groups are men, obviously, in the middle age groups, so 25 to 34 and 35 to 44 for both Black and white men. And if you look at EMS data from about a year and a half in the past, so July 2021 to December 2022, it follows a similar pattern, except the Black men tend to skew older. When you look at the overdose rates, we're seeing a bit more among the older Black population. So that is interesting. But of course, as we've seen, definitely higher rates in Black men than white men. And it's the same with Black women and white women. The rate is in Durham is higher in Black people. And as Dr. Moon has pointed out in the past, that gap is getting bigger and bigger. So we want to make sure that we are enrolling substantial numbers of Black people into our program. And so I dug down a little deeper to do 2 time points from the start of the program to April 30th, 2022, and then from that date to the present. And the reason I chose that date is our peer support specialists before that date were Brittany and Catherine, and they were both Black women. And after that date, we've had Anna and Henry, and then more recently Claire, who are all white people, and just wanted to see if that had any effect. Now it does look like in the later time frame that we were enrolling slightly fewer Black people, but this is the difference of only like 2 or 3 people. So it's not statistically significant. So it looks like we're pretty much enrolling the same percentages of whites and blacks, about 50-50 when we started versus now. But I do think we can do better. We should be getting more Black people. And fortunately, we've received extra funding for the coming year. We'll be able to hire 2 more peer support specialists, and I would really like to make sure that they are diverse. And I'd like to get a man in there, just because I think people feel more comfortable with when they're talking to people like themselves, especially when it's peer support. So that's the end of my presentation, and I'm going to turn it over, I think, to Claire, and we're going to hear some of her experiences being a peer support specialist with this program.
Hey y'all, how's everybody doing? My name is Claire, and I am a peer support specialist here at Durham Recovery Response Center under the CLC program. Give me 1 second so I can pull up this presentation. Okay. All right, can everybody see?
Yes.
Perfect. Okay. All right, so peer support in community and outpatient settings. I'm going to talk about the successes, the challenges, and just kind of overall the lessons I've learned through this job. All right, so I got certified in peer support in July of 2022, so almost a year ago now. When I first started in peer support, I started here at Durham Recovery Response Center, but I worked on the inpatient side. I was considered a recovery coach. So essentially I would work with people in the crisis unit, and I would do somewhat similar job duties that were more short-term, like finding longer treatment, finding housing, things like that. In January of this year, I actually got hired as a peer navigator under CLC. And essentially what my job is now is I work with people on a more long-term scale. So it's still peer support, but I'm looking to help people with more long-term housing or long-term treatment, or if they're looking to get benefits like food stamps or just little things. I've helped people get proper health care, primary care providers, stuff like that. That's more on a long-term scale through their recovery. Let's see. All right. So a big part of my job, and this has already been mentioned once by Lacey, I do post-overdose visits with EMS. So essentially what that looks like is I coordinate with EMS, and we go out into the community for those who have overdosed in the last 72 hours. What we do, me and someone from EMS, we go out and we just follow up with them. I created a resource folder that I give out to everyone, including people on the unit or anyone that I visit for CLC. It's got a bunch of resources with housing, safe ways that you can use, needle exchange, things like that. Just information about certain opiates or certain drugs, just so they have that. And it's all obviously has the CLC information, how to get in contact with me, how to get in contact with the center, everything like that. Something that I have noticed since I started doing this is when we visit people, they're not always happy to see us. It can be a little bit awkward. I have seen people get embarrassed, especially if there were other people in the home, or they just are uncomfortable. I think it's kind of, they, like, Lacey has mentioned, they maybe aren't ready. But what we do is when we approach them, we want to meet them where they're at. We're not there to lecture or to convince them, that they should be clean. But we're there to just be there for them, whatever that means for them. So that is very important, I feel like, is making sure people know that, people like us that are working in this field and we have all this education and, everything like that. We have all these programs. We want to meet them where they're at. We're not above them in any way. We're here for them and there's no judgment, Something I've definitely learned since going out in the community like this is that it makes the issue of the opioid epidemic very much more real. Because while I'm here in the facility, we do see guests and we do work with people, but meeting them where they're at, at the home or the last known location, it really makes it more real. You really see what's going on, you see the environment, and you see the people in their home, in their comfort zone. So it really kind of brings it all together and it really gives you good perspective. All right, so now we're going to talk about some success stories. So something that I know that I have done is throughout at least my year here at Durham Recovery Response Center, I have built a good rapport with guests. I have guests that only ask for me. I have guests that only want to work with me because they trust me. And I'm really happy about that because that was something I was worried about when I first started. I was like, are people going to like me? Are guests going to be comfortable with me? And I have seen overall that they are. So I have 3 success stories here. Obviously, I've changed the names for confidentiality. So the first one I'll talk about is June. So I first met her in October of last year when I was working on the unit. It was her first time in detox. She was scared to death. She didn't know what this was going to look like. She didn't know what was going to happen. I was a person that did her intake. So I was there for her like right when she came in. So some time goes by, she does a detox, she goes back out into the community. And then when I start working under CLC in January, she is an outpatient. She's doing much better. And then I continued working with her. She's got her job, she's back with her family. And it was really, really nice to see that because I saw her, day one. Second person I want to talk about is Allie. She was a referral from the jail. She came maybe some months back. When she came from the jail, she was struggling. She was still using. She honestly was kind of coming here because it was more of an obligation. So once she got here and she realized she could be comfortable, she really liked it. She has therapy. She's actually going back to school, which I've also helped her with. And it's been really nice. And she's really been trying to work on getting clean. She still uses here and there, but either way, I'm still proud of her. She's come a long way. The last person I want to talk about is Hector. He was a referral from Duke Regional. He's an older gentleman. He had never been on our inpatient side. He just came from the hospital and came straight to outpatient CLC. I worked with him on housing because he wasn't from the area and wanted to be in Durham. He actually had diabetes and he wasn't getting treatment for it. So he came to me and said, hey, honestly, along with my recovery and what that looks like, I need help with my health. So, we got him into some diabetes treatment and he has been able to find work and he's doing really good. And I've seen a big improvement in him. So stuff like that really helps. And I know we all know this. It's really helpful when we see the clients or the guests that we work with come far or even take a baby step, what I'm saying, any sort of growth. It's really, really rewarding. So now we're going to talk about challenges, and I can almost guess that everyone on this call can relate to some of this stuff. Okay, so when we work in this field, there is an emotional burden and an emotional load that we do have to carry because of secondhand trauma, especially if we're an empath. We're really feeling the emotions when, guests come to us about what they're going through, how they're struggling, things like that. And another thing that I know I definitely struggle with is if they come to me about something they need help with and I'm just not capable because of something out of my control, whether it's finding housing that is specific to their needs, proper health care, finding programs that are for free that meet their needs. It can be difficult. The answers aren't always out there and it's not always an easy, phone call and get somebody somewhere. And honestly, that kind of brings me to the next point where the issues that our clients and our guests deal with, they're very systemic. They're not here. It's a big thing. Certain programs won't cater to certain individuals, whether it's they don't take people that are on Suboxone, whether it's they don't take people that have health issues or that are disabled. Programs, if they aren't working, won't take them. Things like that, medications or treatments being too expensive. I mean, because sometimes it really just comes down to the money, And it can be really difficult to realize, because that's something I learned very early on, is that maybe can't help everybody as much as I want to, you know. Another challenge is working with guests who can be very highly reactive, have emotional outbursts, you know, even violent clients, what that can be like. Learning how to de-escalate, and honestly taking care of yourself in that moment too, what that looks like, you know, regulating your own emotions, not getting worked up, keeping yourself in check, all of that. It can definitely be a challenge, and it is a learning process that I think honestly comes with the experience. You know, you can take the classes and everything, but until you're faced with it, you really don't know how it's going to be. And finally, kind of related to the systemic issues and implications of the job, sometimes having to tell a guest, you know, I can't help you with this because of these barriers, and we're going to have to find other options, and we're going to have to do this and that and the third. It can be frustrating for them as well as myself, because all I'm here for is to help them. And if I can't, it can make you feel like you're not good at your job, that maybe you're not a good fit, and all of those emotions. So overall, I just want to say that, you know, it does have its challenges and its successes, but most importantly, it has an impact. Every single guest that we deal with, every single client, regardless of how small or like the length of time being small, whether I work with them on just one phone call or I've seen them for a year, there's at least an impact that's left. It can be very rewarding while it can be hard. But overall, I mean, I do love what I do, and helping people is ultimately my goal. You know, that's what's important to me. So now, if anyone has any questions, feel free to ask.
Great job. Thank you so much, Claire.
Absolutely.
Does anyone have any questions? And then we're going to go to Ronald.
Yes. Thank you, Clara. That was a good way of putting it. I want to say hello to everyone and thank you for the invite to the meeting. Thank you, Clara, for reminding me of my job. I kind of miss being out in the community as much as it is challenging, but I do kind of miss it. But unfortunately, I'm working at the Durham County Detention Center, which is another setting. And it's a different setting because of the security risk. So I am currently working up under the leadership of my clinician, Tammy Levon, and I'm working up under her. And my role on a daily basis at this setting is to see the clients and meet them right where they are as well, and introduce them to the population that I'm working with in the facility. As you've seen the numbers that Tremaine presented earlier, alcohol, opioids, and cocaine and marijuana use. We also, he didn't have in his data that I thought should have been there, the mental health piece. So I'm working with people that have a dual diagnosis as well. So it's very challenging when you're working with a person with dual diagnosis because you don't know, how they're going to react to you coming to check on them, especially if they're coming in and they've been on a binge. So the first thing I usually do is to check what it looks like for me on a daily basis. I usually check my alpha sheet to confirm that that client is still there and they haven't been released for various reasons, for maybe posting bond, things of that nature. So once I verify that client is still there, then I go meet with the client, um, fill out a see if they're feeling well, build a rapport with them, and just to see if they're feeling well enough to uh, complete an application. Once I get the okay that and I assess that they're doing okay and they're able to, I assist them with doing a application. So I get them to sign their screening intake form, signing consents form, things of that nature that we need to have consent for, so we can be able to advocate on their behalf with other providers that we'll be working with for their treatment. We offer medication for the opioid use. There are a lot of different common medications like methadone, Suboxone and naltrexone, but we only offer Suboxone at this time. We're looking to move into offering other medication, but not at this time. We're only just offering Suboxone. And so once I do my intake interview with them and get their information and get the consent forms signed and everything, I go back and create a note and inform my supervisor about the readiness of the client. And so that's what that looked like for me once I collect all my information and complete the case management forms and things of that nature. Complete all notes that need to be completed. But one of the barriers that I face sometimes when meeting with clients, the readiness to change. Some of them are just not there ready to change. So I continue to have to meet them right where they are. So, you know, there's a question on our questionnaire that really strikes up a conversation when a person answer a certain number on the readiness of change. If they give me a low number, now we're having a conversation, a real long, good conversation, just trying to find out their stage of change, their readiness to change. And so it always, you know, kicks off a well conversation to encourage the need, you know, in a preventive way. So I do that as well. We also host group twice a week. I facilitate groups twice a week there in the jail. One of them's on Thursday, between Tuesday and Thursday, and the other one's on Friday. I facilitate the RAP groups. So we work on their RAP plan, the Wellness Recovery Action Plan. So we work on that with each individual in a group setting. And it usually takes about 4 weeks. We go through that and they graduate and we'll get another group. And that's what it looks like for me. Now, some of the barriers I feel that takes place in the facility that I'm in, some of the stigma pieces I think plays a big role about medication. Some people thinks that, you know, you're just, I'm pretty sure everybody heard this stigma about you're just substituting one drug for another. But when you're using MAT is not a drug, it's a medication. And so I try to stress that and give them a broader conversation about the medication. Medication helps individuals in recovery and also prevents overdose. So, you know, just having a conversation with individuals about that stigma, and that's just one of the barriers that I hear a lot around in this arena that I'm working in. So we do have a follow-up procedure if an inmate gets released unexpectedly or may post bond or get released on pretrial release or something. We'll do a follow-up with them, make sure they have a treatment provider to handle them outside of the jail once they get out or released. So we usually, if they get started and get inducted with their medication, we'll get the doctor to do a 7-day bridge where they can go pick up their medication. And we'll make them an appointment to get to their medication provider that will be providing their medication so they can continue their meds and their treatment in the community. We do a follow-up just to make sure those guys got to the appointment, and a follow-up for the next 60 to 90 days just to check and make sure everything's going well. And is there anything else we can do for us leading them in with other resources to help them along their way? And that's pretty much what a day looks like for me in the detention center.
Wow, that's a lot. So, does anyone have a question? I do. So My question is, I'm so glad, and I've heard before that there is a release plan. So
Yes,
what I'm
yes.
thinking about is that there are individuals who have not completed their full range of what you have in terms of the program. So when they are released, and they're released with the 7-day
Bridge for medication.
bridge for medication,
Yes.
do you think does that seem like, in your experience, that that's long enough? Do you think it needs to be 14 because of
No, the reason why, Dr. Brooke Boone, the reason why it's a 7-day bridge, it gives them 7 days to get to their appointment. So we're going to schedule them appointment within that 7-day window.
Right.
So
Okay.
once they get so we give them a window frame, and so we not, by being such a last minute, sometimes we try to get that appointment within the 7-day window.
Okay.
So once they get there and get to their appointment, there's no need for us to continue them a prescription. The provider that they're going to will continue their medication.
Mm-hmm. Okay. All right. Well, thank you so much. And we have one more presentation from Dr. Faye Calhoun, which I'll set the screen up for her. And then if there's nothing else, we can move along from here with great thanks for your being here.
Thank you.
Dr. Calhoun, are you ready?
Yes, I'm here. I'm ready. Yeah, we worked so hard to get this conference presented on May the 11th. I mean, everybody, May the 11th, May the 11th. And what was important about this conference is we pulled together over 100 individuals representing many organizations, and one of the they represented the health centers, the community health centers across the state, and not just those that were well funded, etc., but the rural health centers and the free clinics and the individuals that are out there trying to do what they can to support individuals who are opioid use. I call them victims, and so the key word on the first slide over here is the inaugural conference. When you say something is an inaugural conference, it means you're going to have it again. But we wanted to have it, and we wanted to be certain that we had some of the right people in the place, so that the next time we do it, we'll expand it and have more individuals. We planned this conference in such a way that practitioners could earn one continuing education unit. So we had to start the night before the conference with a dinner and some presentations, etc., to be able to get that many hours in of training. And then the next day, of course, was a full day, starting in the morning when the Jacobs came and opened the conference for us. Of course, Wanda Boone was there and did a fantastic presentation in the middle of the day, and along with another number of others. But I guess the key to the conference was the fact that we had three partner organizations working together. Of course, one is the North Carolina Community Health Center Association. That's the HRSA funded State Primary Care Association. And they definitely showed up. Their leadership from across the state and the various counties showed up, even individuals that were trying to, with the approval and encouragement of their communities, they were trying to develop a community health center. And so we had some individuals come in at that stage, and they were very excited about learning how to expand what they had proposed as a mental health area for their clinic to be able to address opiate use disorders. So the NCDHHS was in the house, and they were partner number one. Partner number two, of course, was NCCU's Biomedical and Biotechnology Research Institute, and that focuses on issues and health issues that disproportionately affect minority and underserved populations. So they conduct interdisciplinary and multidisciplinary research, and this is certainly an area. They have an opioid. We have NCCU. I'm from NCCU. We have a opioid abatement coordinating center, and that's funded by the North Carolina Collaboratory to build research capacity across the North Carolina system institutions. You know, there are 17 institutions, universities funded by the North Carolina system that participate in what's called the Collaboratory. Now, the Collaboratory is interested in supporting some research that that is a really hot issue in North Carolina. And recently, of course, opioids came up, and they're focusing on that. They have funded over 400 research projects, and they the North Carolina General Assembly supported them with $148 million. But they have supported projects in areas other than opioid use. But now they are working with them, and NCCU is in a pretty good leadership role for that. So that's the second. Those are the partnerships: the NC Collaboratory, the North Carolina Community Health Center Association, and the BBRI at NCCU. So those three partners pulled together and suggested and worked on the program for this day. Well, let's see. I guess other than Dr. Boone did a presentation to the health centers, and this was followed by a panel discussion. And so we had some of the leaders in the field and the people on the ground, like the people on this particular call that we're on right now. So those who are actively involved were on the panel for that. We had someone that has spoken in this meeting before, Catherine Sanford was there, and she did a presentation on the history and overdose prevention programs, etc. And then in the afternoon of that day, I guess the keynote, you just call it the keynote presentation, because he was on from 1:30 until 4:30. And that was Dr. Samuel Parrish, who's an MD representing ASAM, you know, Addiction Medicine, the Physicians Association. And he did a fabulous job. And you know, one way you know your conference is at least somewhat successful is that nobody leaves. Stay. And they were very excited about Dr. Parrish's presentation because he reviewed the evidence base for medication use in a very comprehensive way. He reviewed the common clinic flow on a typical day of treating withdrawal management issues. He talked about recognizing common barriers faced by clients and patients seeking care. It was just great. And so I just wanted you all to know that that conference was held, that it's going to be held, another second one is going to be held. Now, we did an evaluation. So we sent out an evaluation to those who attended it, and they responded. And now we know there were suggestions. For example, they want breakout groups, or it was suggested that we expand the conference to 2 days. I'm not really sure about that, but maybe we can do some breakout groups. We'll see how that works out. But they wanted more breakout groups so that they would have an opportunity to talk to each other and to talk more of themselves in the conference than to listen, to do more talking. And so that's a great thing. So we're going to have that. I think we had great food, and that might be a reason why folks stayed, but we don't know. Anyway, we're going to do it again. And the next time, I'm hoping that we focus not only on the community health centers, but everybody on this call should be there. And it's going to be great. And I think the continuing education units, and you let me know if that's important to have continuing education units in a conference like this.
Thank you so much. It was a wonderful event. I can't say enough about it. But if I say anything else, Donna will be very upset because she wants us to start and stop on time. And I think we've done so well. We're only 4 minutes over. But in any case, our next quarterly meeting is on Thursday, September 28th. And please look at your emails because the minutes from our meetings are there and some other information. So you can get in touch with us at any time, join all of our groups, any of our groups. And this has been great. I hope that the information has been great for you and you're a wonderful audience. So thank you so much. Mr. Rod, did you want to say anything?
Nope. I've been all over the chat. It's always good to be with you all, and thank you to our presenters. I think my deputy said it best. All the presentations were good. That was done by Deputy Health Director Christian Patterson in the chat, and I concur. +1. Thank you all for all that you do, and we certainly appreciate the Herculean effort.
Okay. Thank you, everyone, so much. Have a wonderful rest of the week, and the weekend is almost here. See you later. Bye.
Thank you, Dr.
Bye.
Boone.
Thank you.
Bye. Bye, Cindy. Hey, Cindy.